So today we are going to keep the entire session where Dr. Manu will present a case of a medullary cancer of the thyroid, and I will request you and Prathamesh sir to guide us through this case.
Yes.
Manu,
Yes, sir.
you're ready, Manu.
Yes, sir.
Please go ahead and present the case. Kannan, are you there, Kannan? I think he's still busy in the theater. Okay, Manu, you can start.
Yes, sir. So the patient is a 25-year-old gentleman, resident of Mumbai, a student, present to the OPD with the chief complaints of two swellings on the right side of the neck since the last 6 months and swelling over the lower anterior aspect of neck since the last 2 months. The patient was apparently all right 6 months back when he noticed two swellings on the right side of the neck, the lower one above the collarbone on the right side and the upper one a little above it. Both the swellings were noticed at around the same time. Both were insidious onset, were the size of a pea to begin with, but now the lower neck swelling has become double its original size gradually, and the upper neck swelling has slightly increased in size gradually. Both swellings were painless to begin with and have remained the same. The patient has noticed another swelling on the right side of the anterior lower neck since the last 2 months, which is the size of a pea from the time the patient noticed and has slightly increased in size gradually from the time of presentation. Not associated with pain, and no history of any other neck swellings, change in voice, breathing difficulty, swallowing difficulty, coughing while swallowing, symptoms suggestive of hypo or hyperthyroidism, night sweats, evening rise of temperature, cough, loss of weight, fatigue, loss of appetite, chest pain, persistent cough, diarrhea, or bone pains. In past history, there is no history of COX or COX contact, diabetes mellitus, hypertension, bronchial asthma, emphysema, ischemic heart disease, any surgical intervention or allergies. The patient is on a mixed diet, bowel and bladder habits are normal, sleep appetite is normal, no history of any addictions, no history of thyroid cancer or any other cancer in the family. To summarize, is a 25-year-old gentleman with a lower anterior neck swelling since last 2 months and two lateral neck swelling since 6 months, with no symptoms of hypo or hyperthyroidism, with no pressure symptoms and features suggestive of dyssynergy.
So what is your conclusion from the history?
Ma'am, from the history, it's a young male with a noticing a swelling in the anterior aspect of neck since the last 2 months, and two other swellings on the lateral aspect of neck on the right side, same side, same side. So I'll my thinking is in terms of a thyroid cancer, a thyroid lesion with a metastatic cervical lymphadenopathy. It could also be a case of lymphoma, because the patient has presented first with lateral neck swellings or tuberculosis. These would be my three differentials.
No, but how do you say with the thyroid swelling you have a lymph node metastasis as a tuberculosis as a diagnosis?
Yes, ma'am. Those are my last two diagnoses. The primary diagnosis is a metastatic thyroid malignancy.
Okay, okay. So let's go ahead. You present the further examination.
Yes, what else are you thinking about anterior neck swellings? This is median or paramedian?
Ma'am, this is slightly to the right side of the median.
So you just talked about thyroid and you talked about lymphoma.
Yes, sir.
What else can you be suspecting?
Other lesions of the median neck swellings like thyroglossal cyst, subhyad bursitis, pretracheal or prelaryngeal lymph node.
What else?
Uh,
If it was a female patient,
Suppose that female patient comes with the dysphagia and got a anterior neck swelling and got a cervical nodes. What will be your differential diagnosis apart from the thyroid cancer?
Uh, could be a anterior neck swelling with a lateral neck node.
So
Could
the
be
patient can basically hypophalangeal cancer, the
hypophalanx.
post-cricoid cancers can
Post-cricoid.
present with the thyroid swelling and can have a propensity to the lateral neck cervical metastasis also. So you may be thinking it is a thyroid malignancy, but the patient must be having a post-cricoid malignancy.
Yes.
Yeah. Any other question? I think we can
No,
go
go
to
ahead. Go
the
ahead.
main examination.
On general examination, patient is alert, conscious, cooperative, sitting comfortably in a chair. He is well built and well nourished. ECOG 0, BMI 22, BP is 122, 6 by 86 millimeters of mercury on right arm and sitting position. Pulse is 78 beats per minute in right radial artery. The respirator was normal. No signs of hypo or hypothyroidism. A local examination, a node of approximate size 1 into 1 centimeter seen on the right side at the level 3. Another node of approximate size 2 into 1.5 centimeters seen on the right side at level 4. No other swellings were seen. On palpation, there is a single smooth nodular swelling of size 1 into 1 centimeters felt in the region of the right thyroid lobe. It moves with deglutition and is non-tender. Skin is pinchable over the swelling. The lower border of the swelling is well felt. The rest of the thyroid gland is not palpable. A firm, irregular, mobile, non-tender node of size 1 into 1 centimeters is palpable at the right level 3. Another irregular, mobile, non-tender, firm level 4 node measuring 2.2 into 1.5 centimeters is also felt. Skin pinched over both the bilateral carotids were palpable. No other nodes or swellings palpable. Trachea is central. This is the clinical picture, the level 3 node and a level 4 node. The level 4 node is of the size of 1 into 1.5, 2 into 1.5 centimeters, and level 3 node 1 into 1 centimeters. And there is uh, a nodule palpable at the level of the right thyroid lobe, 1 into 1 centimeters. No other swellings or nodes were palpable on the contralateral side. A Hopkins examination was done, which showed bilaterally mobile vocal cords. Systemic examination was normal. To summarize, there's a 25-year-old gentleman with 1 into 1 centimeter swelling in the right thyroid region since 2 months, with the right side 1 into 1 centimeter level 3 and 2 into 1.5 centimeter level 4 mobile firm lymph nodes since the last 6 months. Clinically euthyroid, no pressure symptoms. My provisional diagnosis is solitary thyroid nodule on the right side with ipsilateral cervical lymphadenopathy, probably malignant. T1A and 1B M0 lesion.
So tell me, what is the location of this solitary thyroid nodule in the right lobe of the thyroid, where it is situated?
It is located below the thyroid cartilage, around 2 centimeters above the suprasternal notch, and immediately lateral to the right sternocleidomastoid anterior border.
Basically, maybe you need to specify it is a superior pole or an inferior pole, if you can mention, particularly in a thyroid case, because it's a very tiny nodule what you have picked up on a palpation. 1 centimeter is a very difficult nodule in a thyroid to palpate,
Yes, ma'am.
mainly for the sonography person to pick up 1 centimeter. It is usually beyond 1 centimeter which can be palpable to the finger of a clinician. So with respect to the pole, where it is located?
It looks likely to be the upper pole.
Yeah, so that is most important. So what happens if it is a thyroid nodule in the upper pole? What respect to the cervical nodes? What happens to the cervical node?
If the nodule is located in the upper pole, usually the metastasis is in the lateral cervical group of lymph nodes. If it is in the middle or lower pole, it is usually in the central compartment lymph node
Yeah,
metastasis.
so you can have a skip metastasis. So instead of when you have a superior pole involvement with the nodule, they can go directly, the lymphatics can go directly to the lateral compartment. So you will have a skip to the central compartment and directly going to the level 2 and 3. That is the most, and that's how what you are having in this case particularly,
Yes, ma'am.
right? Okay. Um, Anything in examination you wanted to say about contralateral nodes? Anything you got? Contralateral lobe specifically?
Ma'am, the contralateral, the left lobe of thyroid was not palpable, and there were no contralateral swellings seen or palpable.
Okay. Okay, go ahead.
Ma'am, I would like to do a thyroid function test with TSH and ultrasonography of the neck.
No, first let's finish. Anything else any positive findings you wanted to say?
Um,
You finished with the examination and everything?
yes, ma'am.
Okay. Tell me the swellings of how you have concluded that it's a thyroid swelling. What is your clinical examination tells you?
Ma'am, the swelling was firstly the location of the swelling. It was located just below the thyroid cartilage and above the suprasternal notch and anterior to the sternocleidomastoid in the midline, slightly on the right side. Then the swelling on palpation was moving with deglutition.
Why not? It is a thyroglossal cyst. You say one of your differential diagnosis is thyroglossal cyst.
Ma'am, the thyroglossal cyst would move with the protrusion of the tongue. The swelling was not moving with the deglutition of the protrusion of the tongue.
It's not moving.
With the protrusion of the tongue.
Okay. So how you will investigate this patient?
Ma'am, I would like to do a thyroid function test, T3, T4, TSH, along with ultrasonography of the neck and FNAC of the nodes if possible.
So how you will do FNAC? Palpation method or how it is?
Preferably since the nodules are very small, the USG guided FNAC would be preferable.
So always, most of the times now we are in the era where USG guided FNAC is most preferred modality. This actually increase the yield and it can actually characterize the nodule and you can direct a FNAC from the most suspicious part. Okay. So what investigation you will do for this patient as a imaging wise?
Ma'am, ultrasonography with CT scan of the neck and thorax.
Why you want neck and thorax CT scan?
The patient has a lower cervical lymph node metastasis. So, my first investigation will be thyroid function test and ultrasonography and FNAC of the node.
Okay.
Based
So,
on that, I'll proceed further.
okay. So what is do you have a finding of all these three tests? Yeah.
Yes, ma'am. The USG neck showed a right thyroid lobe, which was 6 millimeter, solid hypoechoic lesion. Left thyroid lobe was normal. In the right level 2, 3, 4, and 6, there were abnormal nodes with lobular calcifications with gross to moderate internal vascularity. FNAC from the level 4 lymph node showed metastasis of medullary thyroid carcinoma. And the thyroid function tests were normal. Since it showed metastasis from medullary thyroid carcinoma, we did a calcitonin and serum carcinomeric antigen. Both the serum calcitonin was in the range of 13,000.
Just
And
stop here. Just stop here. Let's come to this three investigation, the basic investigation, which is very common to any thyroid case.
yes, sir.
So what is the sonography tells you? You have a diagnosis of a medullary thyroid cancer. So is it different from the papillary, the findings on a sonography?
The findings on a sonography, ma'am, it could be more or less similar, but FNAC findings will be different. The findings on sonography of a differentiated thyroid cancer or a medullary will be a hypoechoic solid lesion with microcalcifications um with peripheral with vascularity and irregular margins. But in medullary thyroid carcinomas, the nodules may be more lobular or microlobular.
Yeah. So on a sonography, if you look at the differentiated thyroid cancer, that is the papillary thyroid cancer, and the medullary will have a different features. So the echogenicity, then the circumscribed margins, microcalcification, these are very unique to the medullary thyroid cancer. So you can differentiate, but the characteristic findings on a sonography is not so much particular for the medullary thyroid cancer. Okay. So on a FNAC, you got a diagnosis as a medullary thyroid cancer from the lymph node.
Yes,
Why
ma'am.
didn't you do it from the thyroid?
The lesion on the USG was 6 millimeters. It was much less than one centimeters. So the yield of FNAC and the sensitivity of FNAC will decrease.
Right. So what is the sensitivity of FNAC for the medullary thyroid cancer or any thyroid lesion to pick up?
Of FNAC is, ma'am, in the higher end of 90%
For
for differentiated thyroid cancers.
yeah, and for medullary from the thyroid nodule, if you have to pick up,
Ma'am, if it is more than 1 centimeters, it has characteristic features of azurophilic intracytoplasmic granules and samoma bodies and features of
Manoj is asking you what is the sensitivity of medullary CA thyroid on FNAC?
is it high? Is it low? Is it the same as
low.
the differentiated
It's
thyroid?
lower than differentiated thyroid cancers.
Yeah. So it is lower than differentiated thyroid cancer, and it can miss the medullary thyroid diagnosis in 20% of the patients. And it is very good if you do it from the lymph node because the pickup rate, the yield will increase on a FNAC.
Yes, sir.
Okay.
Another thing, Manu, is about the ultrasound. How do you actually report this ultrasound features? You have mentioned this, and you have you know uh, taken this information from the ultrasound report. Is there a particular way you need to report this?
Ma'am, sir, it's usually reported in the form of thyroid, in the way of thyroids. With,
Yes, go on.
so it takes into account the 5 major features of ultrasonography. That is for a thyroid nodule. That is the like hypoechogenicity, solid, uh, um with irregular margins, with taller than wide nodes, and
So basically, you need to report it in a synoptic manner.
synoptic.
So you have to talk about the lobe. You talk about the characteristics of the nodule in the lobe. Then you talk about the lymph nodes, the levels involved, what are the size of the nodes, what are the characteristics of the node if there's an extracapsular spread or involvement of structures, as well as the location. So
Yes.
when you are trying to discern from the report and you're presenting, you need to present it the way you will make a clinical decision. So
Yes.
what features are you looking for on that ultrasound report? It may not have been reported in a synoptic way, but when you are presenting in a case, you need to present it in a form that is understandable. So I understand that you have understood how to read that ultrasound report.
Yes, sir.
Go ahead.
So should I proceed with the investigations?
So how you will now, since you got a medullary thyroid cancer, so how you will work up or further more investigation you will ask for?
Ma'am, apart from the TFTs, I'll ask for the
Of
serum
course, let's go for the history. So anything more history you will ask from the patient. Apart, then we will go to the investigation part.
history of any family history of any thyroid cancer in the first degree relatives.
Only thyroid cancer you will ask?
History of thyroid cancers of pheochromocytoma or hyperparathyroidism.
Yeah, so
True.
you'll ask for thyroid surgeries, parathyroid surgery, adrenal surgeries for the patient. Then any other family history you will ask? Any sudden death
Any
in
history of sudden death in case of metastasis from the thyroid cancer?
any sudden death on a table before anesthesia, during undergoing any procedure, that you should ask, because this will rule out the FIO in the family and the number of members in the family who are affected by the thyroid cancers. That's what you will ask. Anything else you will ask? Since it is medullary as a FNAC. Anything you will look for which you are not looked for because it was only a thyroid swelling?
Ma'am, other features like history of diarrhea in family, skin lesions.
What skin lesion you will see? Where you will see?
Ma'am, pruritic papules on dorsal surface of the body, which improves with sunlight.
Yeah, so you will look at the scapula, interscapular region.
T2,
Any
T2,
pruritic lesions are there. These are called as what?
cutaneous lichenoid amylotic lesions.
So what are these? Can you elaborate on that?
These are associated features with men syndromes, in specifically with men 2A. This patients will have some percentage of patients with men 2A have either a CLA that or a Hirschsprung's disease. In this cutaneous lichenoid lesions, there are lesions on the level of T2 to T6 cervical vertebrae in the region of parascapula, and these lesions are pruritic and papular, which improves with sunlight. And
So the most important thing with relation with the medullary appearance. Anything you know about this? So when it will appear with respect to medullary thyroid cancer appearance or a manifestation? So it usually precedes the medullary thyroid cancer. So if you have the patient who has got already, you should investigate this patient. If it is a family history positive and if you have a pruritic lesion, so it will precede. What you said about Hirschsprung disease, what is it?
ma'am, there is a loss of function mutation in red gene in lower.
Tell me the symptoms, what the patient will come, and then you tell me the pathophysiology. First, you tell me with what patient will present.
The patient will present with difficult it's usually happens in children or infants who have present with difficulty in passing stools.
Yeah. So patient will have some kind of a constipation. Younger patients, again, the medullary will follow after that. So you have to pick up in the children in an early stage if you have a megacolon kind of a symptoms, and then you have to pick up. Okay. Anything else? Anything else? Can you tell me what are the medullary syndromes? Then you will know what needs to be looked for.
Medullary thyroid carcinoma usually present in men 2A and men 2B. Men 2A has usually the medullary thyroid carcinoma along with pheochromocytoma and um, hyperparathyroidism. And in men 2B, usually it
So
is
what you will ask for FIO to rule out? What are the history findings you will ask?
in family the history of sudden deaths on table, or history of high blood pressure, or history of tachycardia.
Right, tremors, palpitation, flushing, all these things you will ask the patient. Okay. What about MEN2B? What will be your history? What you look for?
Patients apart from medullary thyroid carcinoma may have the marfanoid habitus, or history of lesions on the face and body.
So what are the lesions on the face and the body?
Lichenoid lesions.
Lichenoid lesions in MEN2B? No, you don't get it.
No. They have usually marfanoid habitus and
See, even when the baby is 1 year old, 6 months old, you can detect certain things in MEN2B. MEN2B patient walks in your OPD, you know that without doing a red proto-oncogen that this is MEN2B patient. So what are these clinical phenotypic manifestation of MEN2B?
Um, uh,
You heard about mucosal neuromas.
yes, ma'am. Mucosal neuromas.
So where are those?
In the oral cavity on.
So you will get a thickening of the lips. So you will have a neuroma on the lips. Then what about the eyelids? Any particular kind of appearance you get it in the eyelids? So you get a thickened eyelids, you get a thickening because of the myelination, then you get a corneal nerve thickening also, and you will have intestinal ganglioneuromas. And these patients will be having a Marfanoid symptoms. It's not a Marfan syndrome, but a Marfanoid habitat what you will have. So when the patient will walk in, you will know that this patient has got a phenotype of MEN2B, and even in an early stage, younger stage, you should have a suspicion if it is a MEN2B patient, right?
Yes, ma'am.
Okay. So what will be the further investigation now? This is all history what we have discussed. Now tell me about the investigations.
I'll do, apart from the USG NEC, FNAC, and thyroid function test, I'll do a serum calcitonin and uh, carcinoembryonic antigen.
Okay, why you want to do a calcitonin?
Serum calcit, this medullary thyroid cancers arise from the parafollicular cells, which are derivatives of the ultimobranchial bodies. These parafollicular cells secrete calcitonin and carcinoembryonic antigen along with the other secretory products. So uh, uh, this calcitonin is specifically secreted uh, from the medullary thyroid the ultimobranchial bodies or the parafollicular cells. So it is used as a marker for a serum for the medullary thyroid carcinomas, and it assesses the prognosis and the disease severity.
So is there any role of doing a serum calcitonin for a screening test for any kind of a solitary thyroid nodule?
Ma'am, it is.
Did you understood the question? What I'm
Ma'am,
asking?
yes, ma'am. As a screening test, serum calcitonin is not recommended, but for assessing disease severity, and serum calcitonin is a marker.
So, any evidence for it? Like, I have evidence where two people from the Europe said that it definitely benefits for the patients who are detected by the calcitonin screening test, and it is uh, doubtful cost effectiveness. However, the but calcitonin screening test helps. In a European guidelines, there are people who do it for a solitary thyroid nodules.
Yes, ma'am.
Are you
Ma'am, but the recent guidelines from ATA has the recommendation is that because of the cost effectiveness, in a case of solitary thyroid nodule, it is usually not done.
right, right. You are correct, but I'm just saying a few guidelines, and there are like 10,000 more patient has been done a serum calcitonin, and they could pick up the medullary thyroid cancer in an early stage, and they can have a cure rate upwards of a more than 50%. And when you have not done the serum calcitonin as a screening test, there was a hardly any kind of a cure in that group of patient. So you detect early medullary thyroid cancer by this method, right? What about serum CEA level?
Ma'am, serum carcinoembryonic antigen is usually is not a clinical marker of it because it is secreted by other organs of the body. But it is used as a prognostic marker in assessing severity after thyroidectomy after thyroidectomy is done or the resection is done to assess the residual or the distant mets.
Okay. So suppose the patient has got a calcitonin which is normal, that patient can have a medullary thyroid cancer.
Yes,
Suppose
ma'am.
the patient has got a studded meds everywhere, but the calcitonin is normal.
Yes, ma'am. In cases of poorly differentiated medullary thyroid cancers, the calcitonin level may be normal. but the CA will increase, or both may be. The CA will increase exponentially to the serum calcitonin.
Right. So CEA is a early marker
Is
in
a
the,
early differenti- It is a early difference. It is a feature of early differentiation of thyroid cancer.
so it is
Whereas
retained, and when you have a de-differentiation, you will have the CEA which is increased and the calcitonin is not rising, right? So
yes,
you
sir.
can have a non-secretory kind of a medullary thyroid cancer where calcitonin will be normal.
Common.
Okay, go ahead. Next, any other investigation you will do?
Ma'am, I'll do a serum calcium and serum PTH. Also, I I have to do. I'll also do uh, serum metanephrines or non-metanephrines or 24
Let's
hours.
stop here first. You said you want to do a serum calcium. You will do a serum calcium alone test, or which kind of a calcium you will want?
Ionized serum calcium.
Yeah, so you can have a ionic calcium or you can have a albumin corrected calcium. So corrected calcium, you should do it, and a serum PTH you will do. Why you want to do these two tests?
Ma'am, since it is a feature, it is in the it is a medullary thyroid carcinoma. I have to rule out if it is a it's not a hyperparathyroidism.
Okay, right. Okay. Next,
I'll
what
do
else?
24-hour urine metanephrines or non-metanephrines and serum metanephrines available. And
If you have a choice, you have everything available. What metanephrine levels you will do? Which kind of a metanephrine levels you will do?
24-hour urine metanephrines,
Is there any other metanephrine levels are done?
serum metanephrines.
So what are those plasma metanephrine or non-metanephrine levels? When you will do plasma metanephrine levels and when you will do 24, you know what is 24 hours metanephrine level, how you do it, how the patient will do it?
The patient has to collect
Yeah,
the
so the patient has to collect 24 hours urine and then you will do the level of that. It is too cumbersome for the patient. It used to be done earlier, but nowadays what we do is plasma metanephrine and non-metanephrine. That's a single kind of a thing. And if it is elevated, if there is a doubt kind of a thing, it is a borderline on the fence, then you will do a 24 hours. So you will trouble the patient less when you will do a plasma metanephrine. Why you want to do this test?
to rule out few chromosomes.
Okay. So when you will do all patients of medullary, you will do it?
Ma'am, all patients of medullary, if it is a hereditary, if it is there in the family, I'll definitely do it. If it is a sporadic case, the initial or the first case or the index case, I will do a red mutation analysis, but usually it is costly and takes time.
No, first you tell me you will do plasma metanephrine for all medullary thyroid patients or no?
Manu, are you suspecting this patient to have a sporadic or a hereditary MTC?
So there is no family history as such of this patient. There are no thyroid cancers or any other cancers in the family. So this could be
What else?
but
Apart from family history, what suggests that this is hereditary versus sporadic?
so the age group of the patient is in the third decade, which is more towards a hereditary. Sporadic cases usually have in the fourth or the fifth decade.
So your
What else?
so your patient is a young patient who
Yes.
may be in a hereditary group, okay? Because he's in his 20s. So
Yes.
he's a young, early onset medullary thyroid cancer. Okay. Anything else? Why you will do a PO? If the family history not positive, you are not suspecting.
If there is a few present, I would like to do the surgery of that first, because the patient may have increased mortality on table if the few is not operated first.
So you can have a de novo kind of a hereditary, a familiar kind of a medullary thyroid cancer. So you can have a mutation which is the first time happening in that patient who has come as a sporadic as a case, but it will be detected when you do the red proton-cogen. But red proton-cogen report may not be available. In that scenario, you would like to do a pure ruling out before you take up this patient for a thyroid surgery. Now you tell me about the red proto-oncogene.
Yes, ma'am. The red proto-oncogene is present on the 10q12 chromosome. It is usually associated with uh, it is a rearranged during transfection. So it is a tyrosine kinase uh, protein which is mutated. So it is present on different types of different cells of the body, including the thyroid, the parathyroid, the uh, adrenals, and the uh, skin.
What is this mutation? What type of a pattern
This is a gain of function mutation.
and what kind of autosomal type it is?
It's autosomal dominant.
Okay. So, what happens like to the patients? Suppose they are autosomal dominant, and what kind of mutation it is? Is it seen in only thyroid tumor, or it is also seen in the blood cell, peripheral blood cell? You can see it.
It's seen in blood cell tumors as well. In
Single point germline mutation means every cell in the
the
body,
body has.
even in the blood cells, in the leukocytes, you can pick it up. So if you do a peripheral blood smear test, you will detect the germline mutation. So it's a single point kind of a thing. What do you mean by somatic mutation?
Ma'am, somatic mutations are the mutations which are usually sporadic mutations which are present in the non-germ cells of the body. That is the the cells other than the gametes.
So it is only present in the tumor. Basically, if you have a particular cell, isolated cells, which are showing the somatic mutation, it is not
Present in the
present
blood.
in the every cell of the body, right? So
Yes, ma'am.
somatic mutation. Can you have a somatic mutation in a sporadic thyroid cancer?
Yes, ma'am.
So how far you can see it and what kind you can see it, and what is the prognosis if you have it?
Ma'am, somatic mutation in a uh, sporadic thyroid cancer. Ma'am, somatic mutation in a sporadic thyroid cancer won't be transmitted to the next generation, though the prognosis, ma'am,
So if you have a somatic mutation for 918, then it is a bad
bad
prognostic.
prognosis. Yes.
Okay, means you may not be having a mutation as a germline mutation, but the somatic mutation in a tumor can manifest into a poor survival. Okay, go ahead. Any other investigation you will do?
Ma'am, since the serum calcitonin is raised, like it is in the range of 13,000, I would just it and carcinoembryonic antigen is also raised 65.72, which is also raised pretty much. So I would like to do a investigation for distant metastasis.
So what is your choice of investigation for a distant metastasis?
Ma'am, could be a CT scan of the thorax with a MRI or a CT of abdomen.
So somebody just wrote on a group on a chat that the PET scan to be done. Do you want to do a PET scan?
For ma'am, for initial investigations, the PET scan that is the FDG PET or the DOPA PET has less sensitivity, so it is usually not recommended as per the ATA guidelines.
So what all investigation you will do? Tell me again.
Ma'am, CT scan chest, CT or MRI of the abdomen
For the head and neck region, what you will do? CT scan of the head and neck,
of
right?
the head and neck. Yes, ma'am.
Then for the chest, what you will do?
CCT contrast in a CT scan of the thorax,
Okay.
HRCT thorax,
Then coming down for the liver, what you will do?
MRI of the abdomen or a
Pardon?
CT of abdomen. Both have more or less equal sensitivity.
I didn't get you. For the liver, what you will do?
MRI abdomen.
So MRI or a CT, a triphasic CT or a MRI for liver is good enough. And what else you will do?
A
For the
bone MRI or a bone scintigraphy.
so what kind of a bony mets are there in medullary thyroid cancer?
Osteoblastic mets.
They are lytic mets. So
Sorry.
in medullary, you have a lytic met. So you will do a bone scan and you will do a MRI for the axial kind of a bony mets ruling out. Okay. So these are the all investigation you will do for the distant metastatic workup for any time in a per primum or a recurrent setting whenever you have a higher calcitonin level.
Yes.
Okay. But if you have a calcitonin which is sky high, very, very high, then you can do a one investigation, that is PET scan for this patient for the initial workup, just to know where all the distant mets are there, because this tumor looks a very, very de-differentiated tumor which has got a serum calcitonin is very high, means there is a distant metastatic load which is high enough to pick up on a PET scan. Okay, right. Okay, what else you will do for this patient? Suppose you have a red proto-oncogen report available, and the report says patient does not have any germline mutation and negative for the mutation, and the patient doesn't have any family history, patient does not have any history suggestive of any kind of a syndrome. So do you need to do all these investigations which you have done for a PO to rule out and to rule out the hyperparathyroidism?
Even though if the patient does not have a RET mutation, he may have other mutations, and around 0 to 9% of the patients with MTC who don't have RET mutations also uh,
So it's a very tricky question. Most of the time, you won't have a red proto-oncogen report available when you're operating this patient. So you will anyways will do all this test on a safer side. But having said that, if you have a red proto-oncogen positive negative, then you can avoid doing this. But all surgeons will still will do a FEO just in case the report is faulty or the kind of a small component where the germline mutation may not be showing. So you will do a FEO just to rule out. Parathyroid hormones is not so much of a concern in a per primum setting, right? Okay. So what next you want to tell me about this investigation for this patient?
we had done a DOTA PET CT for this patient.
Yeah.
68 gallium dotted PET scan, that is the somatostatin receptor scan, which showed a heterogeneously enhancing, partly necrotic, mildly enlarged level 3 and level 4 nodes with specks of microcalcifications which are present, show low-grade SSTR expression. SUV max was 3.2, and there was a small hypodensity seen in the right lobe of thyroid measuring 9 millimeters, barely higher than the physiological thyroid tissue tracer uptake, and few subcentimetric pretracheal, paratracheal, mediastinal, and bilateral hilar nodes. SUV max was 3.4. The rest of the neck, thorax, abdomen, pelvis, and osseous is normal. The impression was possibility of medullary thyroid carcinoma with cervical lymph nodes.
So which one is better? DOTA PET is better or FDG PET is better in a per primum setting?
Ma'am, DOTA PET CT is slightly better than FDG PET in terms of sensitivity, because the receptor for this is present in most of the medullary thyroid carcinoma, that is the somatostatin receptor.
The PET scan is far better to pick up the basically the prognosticating this metastasis. So if they are FDG picked up, then they are little poor prognostic factors. And DOTA PET is basically done when you want to know whether they are responders, they are picking up the somatostatin receptors are positive or no. So you can treat them if you have the drug which is basically you can do a therapeutic DOTA treatment for this patient, then it has got some value. So per primum setting, you may want to do a FDG PET for the patient, and DOTA you can reserve in a recurrent setting where you want to know what kind of a recurrence this is. This tumor has got a prognostication wise, is it going to have a therapeutic DOTA scan, you can treatment, can you do it for this? So that's why you will do a diagnostic DOTA, and therapeutic DOTA you can do it after knowing the kind of lesions. Okay, yeah, go ahead.
Um,
So how you will treat this patient now?
since the calcitonin is in the range of 13,594 and the PET CT has picked up some pretracheal, paratracheal, mediastinal, and bilateral hilar nodes, I will do total thyroidectomy with bilateral central neck dissection with a bilateral lateral neck dissection.
Okay, so what will be your bilateral lateral neck extension? What all neck nodes level you will address?
The 2, 3, and 4 lymph nodes.
So
Level
you,
2, 3, and 4.
so you will do only bilateral 2, 3, 4.
Ma'am, the 2, 3, 4, and 5.
Okay, and the other, so right side you will do 2, 3, 4, and 5. What you will do for the left side?
We'll do the same on the left side.
What, 2, 3, 4, and 5?
Yes, ma'am.
Yeah, right. Will you add
Manu,
a
why will you do a bilateral neck dissection? Why are you doing addressing the contralateral neck? This patient has a solitary thyroid nodule. All lymph nodes are on the right side.
So the serum calcitonin, which is in the range of 13,000, and in patients with medullary thyroid carcinoma, when you have unilateral neck metastasis, that is a lateral neck, there are high chance of contralateral neck metastasis.
So is there any recommendation that you need to do bilateral or you can do unilateral?
So the AT recommends that if the calcitonin level preoperatively is more than 500, you can do a bilateral lateral neck dissection.
You should do or you can do.
You should do.
So why should you do it? What is the basis of doing a bilateral neck dissection?
Sir,
Do
first,
you think that this 13,594 calcitonin will come down to normal?
no, sir. There is a high chance of lateral neck metastasis if there is already a unilateral metastasis. Then these patients will be non-radio iodine avid. So the first surgery will have to remove all the possible nodes to prevent
I
the
didn't get
complications.
what non-avid, what you said?
Non radio
You mean to say there are no adjuvant therapies in form of radioiodine for a medullary CA thyroid?
Yes, ma'am. Yes, sir.
So the incidence of occult metastasis is high. It increases with the increase in calcitonin levels.
Yes, sir.
There's a possibility that you have a contralateral central compartment as well as contralateral lateral neck. And that's the reason you will do bilateral neck and bilateral central compartment. So you need to be very clear when you're talking about what kind of surgery you're going to do.
Yes, sir.
There are hilar lymph nodes. Would you actually address those lymph nodes?
No, sir.
Why is that?
Because of increased risk of complications with addressing the hilar lymph nodes.
So then why doing the lateral neck nodes?
Sir, if according to the recommendations, if there are no patient does not have any much symptoms, you can do the total thyroidectomy with bilateral neck dissection and the
So
central.
when would you address the mediastinum? Or you'll never do a mediastinal nodal clearance?
Sir, if the post-op calcitonin post-operatively after 3 months, the scan is still showing a high level of serum calcitonin and the hilar lymph nodes are still picked up on imaging, I'll do the hilar lymph nodes.
Are you sure?
No, sir.
Hilar is different from mediastinal. Manu, sir is asking you about the mediastinal lymph nodes.
So mediastinal
What can be cleared from the neck and when do you actually need a sternotomy?
So in case of the superior mediastinal lymph nodes, a clearance, it may need a sternotomy.
So you can clear this level 7, that's the superior mediastinal nodes,
Yes, sir.
from the neck itself. If you have level 7, beyond level 7 lymph nodes, you would need to do a sternotomy. So these are, you have to actually categorize when they say paratracheal and hilar nodes, where exactly are the nodes? Most of these nodes can be cleared from the neck, and you need to clear the level 7 as well. So level 7 is a superior mediastinal nodes, which can be cleared from the neck.
Yes.
Yeah, Anuja.
So tell me about the central compartment clearance. What all stations you will clear in the central compartment?
We'll do the bilateral central compartment clearance, ma'am, from the hyoid to the innominate artery on superior to inferior and between the two carotids.
So
Level 6.
what are the stations? 4 stations comes into central compartment. Pre-laryngeal.
Prelaryngeal, pretracheal, paratracheal.
So right and the left, paratracheal, right?
Yes, 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 ma'am.
Right. And as Dr. Prathamesh has said that you will do the superior mediastinal clearance from the cervical approach when your calcitonin level is, what is the cutoff to consider for a superior mediastinal clearance?
Ma'am, about 200.
So above 500 is for superior mediastinal clearance, and about 200 is for the contralateral neck to add it on to your ipsilateral neck dissection. Okay.
Yes,
And beyond 500, and when you have a very, very sky high serum calcitonin, whether to do a sternotomy or whether not to do a sternotomy, whether to stage it, all depends on the kind of a disease burden for that patient and how you have worked up this patient and what kind of a metastasis are present for the patient. Okay, so
yes,
you may stage it, you may do it at the same time. So all these factors, the serum calcitonin level, if it is very, very high, the biochemical cure is less. You must have lost the battle already. So you want to have a better local control. And how many metastatic sites are there? So depend on that, you will decide whether you want to add a sternotomy or no. Once you achieve a R0 resection above the clavicle and superior mediastinum, then you will take a call, SOS, to do a sternotomy, provided there are not meds, major meds in the body. So that's how you will decide whether to do it simultaneous or do it as a stage manner or what needs to be done, right?
yes, ma'am.
Okay. So anything else you will do for this patient? What will be your approach when you're doing a surgery? Why total thyroidectomy? I will say, suppose there is a patient who has got a small nodule of a 1 centimeter, does not have a cervical mets. I want to do only hemithyroidectomy for this patient. So, what you any evidence for that? Doing only
And
hemithyroidectomy?
patients with red mutations for thyroid cancer of unilateral side will develop the lesions on the opposite side up to the range of 100%. So it is usually advisable to do a total thyroidectomy.
So you mean if the patient is a red positive, that is a hereditary type, the patient is going to have a multicentric disease and the patient is going to have a C cell hyperplasia on the both the sides near the ligamentum berry area. So that's why to clear those two areas of a C cell hyperplasia, you will do a total thyroidectomy. I said when you can do a hemithyroidectomy in a medullary thyroid cancer. Anybody from Japan, you know, they have actually propagated doing a hemithyroidectomy for a medullary thyroid cancer? Any group of people you know?
In patients with non-red mutations
Yes.
with normal calcitonin levels in
Less than 20 picogram ml calcitonin level and
small lesions of nodular lesions of thyroid which are less than 1 centimeters.
yes, and without any cervical metastasis,
Yes.
they have propagated doing a hemithyroidectomy, doing a central compartment and the lateral ipsilateral neck dissection and not addressing the contralateral lateral compartment or a thyroid. So So these are the group of people, Miyachi and Ito's group from the Japan. They have a study which they have looked at, but these are the very rare group of patients. We usually in India don't see a patient with a so low calcitonin. We always see the patients with the big nodes, big thyroid swelling, and with a distant mets as a presentation with the medullary thyroid cancer, right?
Yes,
What you will do with the parathyroid during the surgery?
if it is a case of hereditary thyroid cancer, I'll and if there are serum calcium and serum PTH are elevated, I'll see for and remove the enlarged glands, uh,
So
and
you remove all the parathyroid gland, or what you will do?
remove only the enlarged glands, and if all the glands are enlarged, I'll leave a part of the parathyroid gland in in uh, in place if the vascularity is good. Otherwise, if the vascularity is lost, I'll leave it in the if it is a meant to be mutation or a sporadic case, or a meant to A mutation with less incidence of hyperparathyroidism, I'll keep it in the sternocleidomastoid muscle on the same side. If it is a meant to A mutation with a high incidence of hyperparathyroidism, I'll uh, I'll keep it on a heterotropic site like the brachioradialis muscle, so that if related hyperparathyroidism occurs later, I can remove it later.
Yeah. So you will devascularize parathyroid. You will confirm by frozen session. The remaining parathyroid you will store in a isotonic cold saline. And then once you get the frozen report positive, you will implant on a non-dominant heterotropic site, that is a brachioradialis. And if later, if the patient manifests, you can take out that graph area, and you can put a tagging sutures, like you can put a prolin 50 in the muscle wherever you have made the pocket, so you know the identification when you go back in that area, right?
Yes,
Okay. So you said about the parathyroid. So when you will, suppose this patient would have had a high plasma metanephrine levels, so what you will do?
I'll do a CT scan of the abdomen to confirm the location of the pheochromocytoma if present of the in the adrenals. Do a system EB scan to confirm the location further, and if it is there and the metanephrines are raised, I'll probably remove it uh, before doing the surgery for thyroid cancer.
Yeah, so you will do adrenal imaging only if it is a abnormal plasma levels are found. Means if you have a doubt and you have confirmed it, then only you will do investigation, and you will treat it beforehand before going for a major surgery, any kind of a surgery. You will take out the FEO, treat it, and then you will go ahead with the thyroid surgery, right? Okay.
If,
So
if it is bilateral FEO,
So bilateral FEO can also be removed. Subtotal removal can be done with before and after separation, before and after pre-operative and post-operative doses of mineralocorticoids and glucocorticoids.
why subtotal? Can you do subtotal or do you have to bilateral total?
So bilateral total can also be done. There's a group which has sorry sir, total bilateral total.
So the thing is, when you have a subtotal, you do it. The thing is, your requirement for the replacement is not there, and there are less chances that it will get involved later. So you can have a 20% chance over a 20 years time, it can come back, and till that time, at least you have spared the patient with having some kind of adrenal crisis and all that. So you will try to do a subtotal, but if it is not feasible to do it, then yes, you can do a total. But if you can spare the cortical thing, it will be good for the patient, for the recovery point of view, and the clinical problems which he can face after doing a bilateral adrenalectomy, right?
Yes, sir.
Yeah, so you can do a laparoscopic, or you can do a retroperitoneal
Appropriate, yes,
approach,
sir.
whichever. There is no difference between the two as such, right?
Yes, sir.
Okay. and the patient will be always in a need of a replacement, and he should carry the card if he goes into the crisis. So those all things has to be kept in mind, right? uh, Anything about the, now this patient turned out to be a red proto-oncogene positive, so how you will deal with the genetic counseling for this patient?
Since the patient is young, around 25 years of age, I'll counsel the first degree relatives first and screen them for red oncogene. Uh, if present, I'll do the calcitonin and serum carcinoembryonic antigen. If they are raised, I'll do a prophylactic thyroidectomy. If the red proto firstly the red proto-oncogene, if it is positive for family members with 918 mutations, which is the highest risk, and if they
Can
are
you tell me the risk criteria? What are
uh,
they?
there are three risk criteria. First is the highest risk, which includes the codons of 918 red proto-oncogene.
N918T is the codon which is the highest.
Highest
What
risk.
is the characteristics of that? If
It
you
is
have
usually
that
associated with.
germline mutation,
Sorry, ma'am.
if you have that germline mutation, what is the characteristic you get it as a
Ma'am, usually it presents. It is usually associated with men 2B syndrome. So it is usually present in the first or the second. Usually in the first and maybe in the second decade of life, and it is very. The prognosis is bad,
not
and
decade. It's not decade. In the first few years of life, they will manifest into a medullary thyroid
thyroid
cancer.
cancer. So you'll advise for a prophylactic thyroidectomy at the time of diagnosis or below before if the patient is an infant before 1 year of age.
Yeah, so you can do it at the age of like 1 month or as soon as possible, and you will try to do it before first year of life. What about this? So you will do a prophylactic thyroid surgery for this patient, right?
Yes, ma'am.
So and what is the next risk criteria?
The high risk criteria, which includes uh, 634 and 883 codon mutations,
Which one? 630,
634 and 8883,
634 and
883.
883, right? And what is the third criteria?
The moderate risk, which includes other than these mutations.
Right. So, what is the prophylactic surgery age limit for doing for the second criteria, the age criteria?
Is before the screening should start at the age of 3 years,
Right.
and with 6 monthly screening with calcitonin and carcinoembryonic antigen, and preferably below 5 before 5 years of age, thyroidectomy is advisable.
So, do you know any fallacy of doing a serum calcitonin level in this group of patient in an early stage
Ma'am,
for 3 years of age?
children with before 6 months have high basal level of calcitonin, that is in the above at just the basal limit is 40 picograms per ml, and from 6 months to 3 years it is usually 15 picograms per ml. So you may see the calcitonin level and think of the calcitonin being raised and do a thyroidectomy.
So the calcitonin level is not a marker or it is not a guiding tool for deciding the total thyroidectomy or prophylactic thyroidectomies for these patients when in the early age. So before 3 years, you don't look into the serum calcitonin level and decide any management for the patient just because they will have a high calcitonin level. There used to be a scenario when the red proto-oncogene was not available. People used to do a total thyroidectomy and they were not even a part of any kind of a germline mutation, or the patient was not even manifested. Okay, so you don't do it on that basis. What will be the age limit for doing it for the moderate group?
Ma'am, the screening starts at the age of 5 years with calcitonin levels, and preferably at the high calcitonin level or before 10 years of age.
So you will do beyond 5 years, and you can have a calcitonin as a guide for you when you will do it, and then you will decide according to your imaging, depending on the severity in the family, everything you will put together, the clinical criteria, the familiar history, the type of a mutation, and then you will do as early as possible after 5 years. What is the problem doing a early surgery? What is the pediatric thyroid uh, problems?
Ma'am, if early surgery is done, the parathyroid, because of the parathyroid glands are very small, and the vascularity is also very feeble. So the patients may have lifelong hyperparathyroidism in case of in children. So uh, the central neck dissection is only done if you can preserve the parathyroid tissue.
Yeah. So you will do it central compartment if you identified the parathyroids, and the parathyroid in the children does not show as a tan color how you get it in later in the life. They are translucent and you cannot differentiate from the fat in the neck, and the structures are very very tiny. So you may require expertise, you will require a magnification, and if you can identify the parathyroid, then only you should venture for the central compartment dissection. Or if the calcitonin level is more than 40 in a age group more than 3 years, then you can do the central compartment once you have secured the parathyroid, and then you should do it. Otherwise these patients have got a high chances of hypoparathyroidism in a later day, right? So can you tell me why prophylactic thyroidectomy is so popular for medullary thyroid cancer? Why there is no prophylactic cancer surgery for most of other type of a cancer? Any particular criteria it fulfills? Do you have any idea?
Prophylactic surgeries are done only if fulfill some criteria, like if the there is an accurate test which detects accurate imaging modality which detects the lesion. There
Which
is
accurate
uh,
test?
the red mutation.
Yes, so it is a highly reliable test. So you cannot have a falsely positive test. And there is a lots of impact of having a positive test. So it is a germline mutation, foolproof kind of a highly reliable test. That is the red proton protein. Then
Then if the removal of the lesion can removal of the tumor can be managed by post-operative treatment.
so what you will do for the patient after doing the thyroid surgery?
Calcium supplementation and this thyroid supplementation to maintain the patient euthyroid.
So do you require a suppression in the post thyroid?
No, post-thyroidectomy in medullary thyroid cancers, suppression is not required. Only
Right.
the maintaining euthyroid status is.
Third criteria.
Um, um, there is a specific marker available uh, for
What is the marker?
calcitonin,
So
serum
serum
calcitonin.
calcitonin is available for doing a monitoring of the patient on the long term time after doing a thyroid surgery. Then what else? The most important thing. In hereditary thyroid cancer, the penetration of a medullary
Complete
bone
penetrance.
is very very high. It's upwards of like 100%, you can say it. Okay, so the most of the all the patients whoever has got a germline mutation are going to manifest with the medullary thyroid cancer, so there is a point in doing a total thyroidectomy. What about a hyperparathyroidism? What is the penetrance of that component in me and 2a patients?
Ma'am, penetrance is less. It's not complete penetrance.
Yeah, so it is about like a 40%, 50%, depending on what you're having. Okay,
Yes,
so that's why you don't do a
prophylactic,
parathyroidectomy in all the patients.
yes,
What about the FEO? Are you
similar
doing the FEO
incomplete
prophylactically?
penetrance.
No, we are not doing FEO prophylactically. Again, the penetrance is not so much. It is only 40 to 50%.
Yes, ma'am.
So again, whenever they manifest, that time only you do it. And the problems with the doing a surgeries are more than doing a thyroid surgery, right?
Manu, why are you doing the surgery at a young age? Why can't you wait till 5 years?
So the severity of the disease will increase with as the age progresses, and other uh,
But
the
it is not manifest. This patient has not manifest. So why are you doing a prophylactic thyroidectomy?
so in this patient.
Yeah. No, not in this patient. In a pediatric patient, why you do a prophylactic thyroidectomy if the patient has a germline mutation?
So the patient has a general germline mutation, which in course of time will be manifesting in the thyroid as a thyroid cancer, and the severity will be more.
So how much time does it take for manifesting or transformation of the hyperplasia to malignancy?
So in men 2B or the 918, uh, when the mutation is in the highest risk, it takes uh, so it's usually within the first year of life.
And you've got a lot of help from the chat. You know, there's a higher risk that it will not only manifest, it will have a metastasis. So you're going to pick it up before you have metastasis. As Anuja said, you would have lost the battle if you have a metastasis. So that's the reason you want to do a prophylactic surgery as soon as possible.
Yes.
So the one more reason is surgery is the mainstay of a treatment in a medullary thyroid cancer. You can cure the patient if you can pick up and remove all the precursor and the medullary thyroid cancer from the body. And if it is above the clavicle, if it is only confined to the thyroid gland, the morbidity is less, you can control it better, and you can remove it better, and you will have a good control and the cure rate. And the if you have a MEN 2B, then you will lose the pattern after 1 year only. So in an early stage only, if you are not picked up, already they will have a distant mets, and these are the patients who are not going to live longer. Even MEN 2A, the patients who have got a 634 kind of a mutation, these patients will have a high burden of a cancer, and these patients you cannot cure. Whoever has got a calcitonin in 1,000 range. Okay, so the battle is before it manifests totally. C cell hyperplasia into a microcarcinomas, then microcarcinoma into a localized cancer, then it will go to the central compartment, then it will go to the lateral compartment, then superior mediastinum, and then it will go to the distant mets. That's how it goes as a pattern. So you have to arrest it, you have to pick it up as early as possible so that it does not manifest. And each gene mutation has got a typical genophenotype kind of a correlation. So you have to pick it up, and that's why there is a age appropriate criterias are set depending on the retrospective study, the kind of a family studies has been done across the world. They have come down and honed down to these criteria so that you can pick up this patient early. Do you have any papers or anything literature which says that you will cure this patient by prophylactic thyroid surgery if you do a age appropriate surgeries?
Sorry, ma'am. I
Just
don't.
if you delay it, whenever it comes, or whenever they walk inside your OPD, or whenever they feel now they are ready for the surgery, they will come up.
Sorry, ma'am. I don't know.
So there are few papers which actually looked at if you do a prophylactic thyroid surgery, there is a 0% chance of having recurrences. But if you do a non-age appropriate surgeries, then they will have a manifestation. You will feel in 50%, 27% of the patients if you don't do a age appropriate surgery. And it's like 12% increase per year if you delay it. Okay, so there are good papers in new, even in NEGM paper is there, so you can look into that, that the how good is the prophylactic thyroid surgery. Okay, any other points you want to tell me about medullary thyroid cancer? As a recurrence case, what you will do?
Recurrence case, I'll do I'll first the serum calcitonin level to see how much uh, is the uh, level of recurrence and whether it is a local regional recurrence or a distant match by
How
imaging.
often you will do the serum calcitonin in a post-op period?
First, I'll do after 3 months from the surgery. That because it takes around 3 months for the serum calcitonin to reach the nadir. Then I'll if
Half-life of a calcitonin, how many amino acids? Do you have any idea?
32 amino acids.
So what is the half-life? Why you have to wait for 3 months?
Ma'am, if the usual half-life of calcitonin, it has a slow component and a fast component. The slow component is around 1 hour and the fast component is 30 hours. But after resection, the half-life is around 1 month,
So can
around
you
three
use
months.
the calcitonin level as a cutoff for intraoperative assessment? Anything you know about it?
Because
You
it
have
has
a
a slow
PTH.
has a fast component, which is the half-life is 1 to 3 hours. We can see for the halving of calcitonin levels intraoperatively,
So
which
if you
can
have a 50% drop in 10 minutes time, and if it is drop is not means not seen after 30 minutes, you may add some kind of a compartmental more surgery to do a better control. So people have done a serum calcitonin intraoperatively, how we do a PTH intraoperatively for the assessment. But that's again a small group of people who do it. Okay. So calcitonin level post-op, what is the cutoff to actually evaluate the patient further?
ma'am, the cutoff post-op is if for any residual lesion is anything above the basal level or 15 picograms per ml,
So
and
150 picogram, if you
is
have
for
a
distant meds.
calcitonin higher, once it has reached normal level, and then if it is increasing to 150,
50
then you
picograms
anything else you will look up apart from the absolute value?
of ma'am, the ratio of
Yes.
the calcitonin ratio, that is the pre and post-op calcitonin levels.
Okay.
So to see for the calcitonin doubling time, if it is
You
more
will
than
look for the calcitonin doubling time. You will look for uh, basically the ratio of calcitonin, the procalcitonin
procalcitonin to
with the
calcitonin.
calcitonin ratio. So if you have this ratio is abnormal, then you know that this patient is not going to do well.
Yes.
Okay, but nobody do the procalcitonin level because it can get a different kind of a values when you have a infection or other inflammatory diseases and all those things. So septic focus if it is there. Okay. So what is
So when would you do the calcitonin doubling?
In follow-up of the patients, I will do a calcitonin doubling with the reference ratio from the preoperative levels and see if the doubling is about 2 years, is after happens after 2 years, then it has a good prognosis. Before 1 year, it has a bad prognosis.
So it is not just one time test. It is a series of tests which will tell you about the increase. So
Increase.
you have to do at least 3 to 4 samples in order to understand the doubling
Doubling.
time.
so you will
Will
start
you do the CEA levels? Yeah, sorry, Amanda, go on.
So you will do it from the 3 months post-operatively, and you will take the first 4 readings till 1 year. These are the most appropriate things to do it to actually calculate the serum calcitonin doubling time. And if it is less than 6 months, then it is a poor prognostic factor. And if you have it in between, like 6 to 12, it is intermediate, and more than 2 years is a good prognostic. So your survival also will drop down if they are having a early doubling time, right?
Yes.
You were saying something. You were
So
asking
go on.
about CE. You were asking.
Manu, you'll do the CEA levels as well.
So if the calcitonin levels are raised, then I'll do a carcinomyronic antigen test also to see the severity of to know the disease progression. But routinely, it is only the calcitonin levels and thyroid function test and serum calcium are done.
Actually, ideally, you should do both. Even in a pre-operative setting and a post-operative setting, you will do both because you will know the differentiation where the tumor is leading the patient. Okay. Do you know anything about dynamic risk stratification? Is
Ma'am,
there a dynamic risk stratification for the medullary thyroid cancer, or it is only for differentiated thyroid cancer?
in medullary thyroid cancers, if the patient has a high calcitonin level preoperatively and the patient is maintaining on a on a normal calcitonin or less than 150 picograms per ml
Not
post-operatively on.
correct. It's not correct.
Okay.
Okay. So dynamic risk stratification is mainly done for the post-operative period. You want to re-stratify the patient after you had done a surgery again. So same principle as the differentiated thyroid cancer. So whether you have an excellent response, incomplete response as a biochemically, or incomplete as a biochemically and structurally. Okay. So that's how you will group the patient and re-stratify, re-stratification of the medullary thyroid cancer. Okay. So tell me about doubling time with CEA. Is it good enough as a calcitonin or no?
Not so much when, because CA is also produced by other cells of the body, and it's not a very specific marker for MTC.
Okay. Suppose the patient has got a recurrence. So how you will manage it? What kind of options are available in a recurrent staging?
I'll do this serum calcitonin levels and do on based on the values. With the help of USG or imaging, I'll find out where the recurrence is. If it is a locoregional recurrence, uh, a compartmental clearance of the involved nodes or the residual thyroid tissue can be.
Compartmental neck dissection.
Yes, from compartmental neck dissection of the nodes or the, and plus the residual thyroid tissue can be done. And if there is a if the metastasis is in the distant, if there's a distant metastasis, uh, the patient is asymptomatic, uh, and or the elevated levels of calcitonin are not so much, the patient can be observed. Otherwise, if the patient is symptomatic and the serum calcitonin is severely elevated, we can go ahead with uh, the systemic therapies or radiation,
What,
EBRT.
what are the systemic therapies?
The systemic therapies are mostly the tyrosine kinase inhibitors, the vandatinib and cabozantinib.
Cabozanthine and a vandatinib. What is vandatinib? Where it acts?
It is a tyrosine is a multi-tyrosine kinase inhibitor with a VAGR inhibitor, which acts on the red proto-oncogene.
So it acts on the wedge, it acts on the RET, it acts on the EGFR, three kinase. So multi-kinase approach. And what is cabozanthine?
It is similar to, I don't know exactly the.
So it again acts on the RET, it acts on the VEGF2, and it acts on the CMET. Okay. So why you want to give these drugs? What are these drugs? How it helps? How it
These
improves?
are targeted therapies which act on the specific mutations on specific genes. So there are studies, and it is FDA approved in 2011 to be used for systemic therapy in a case of distant mets.
Basically, whenever you have a distant metastatic high load and all other modalities are failed, then you can consider for a progression disease or a stable disease. In that scenario, you will give this targeted therapies, and these patients have shown a progression free survival with a improvement when you are given these drugs. Okay.
Yes, ma'am.
Right. Any other chemotherapeutic drugs you can give?
Single, multiple drug regimen with the doxorubicin or a 5-fluorouracil with a dacarbazine can also be given, but the toxicity is much higher.
Okay. Anything about radiation you can tell me when you will radiate medullary thyroid cancer?
In cases of R plus resections or extrathyroidal extension or distant metastasis or
Distant metastasis, where you will radiate? All distant metastasis you will radiate.
in case of the brain metastasis or liver metastasis, we can give stereotactic radiation therapy, and in bone metastasis.
Okay. In liver metastasis, what are the other options?
Therapeutic chemoembolization.
Okay. Okay. So,
What are the adjuvant therapy for this patient? You have done a bilateral neck dissection. And have you done the surgery for this patient?
No, sir.
No. So suppose you get bilateral lymph nodes are involved and there's extracapsular spread. There is lateral and central compartment lymph nodes positive. Is there any adjuvant therapy you will offer this patient for loco-regional control?
Sir, radiation can be offered to this patient.
So would you radiate this patient if you've done a complete resection?
So I didn't. If there is a extracapsular spread with lateral and central compartment nodes positive.
Yes.
No, sir. Then I wouldn't radiate this patient because there is no extrathyroidal extension or the resection.
So there is not much evidence that you would benefit this patient from
Radiation.
giving adjuvant radiation. So only if you have done an R plus resection and you have had extracapsular spread, you would want to consider.
Yes.
Is there a role for treatment with the somatostatin if it is picking up, if the DOTA scan is strongly positive, and would you give PRRT for these patients? They have a lot of diarrhea.
The labeled octreotide has been tried for patients which are somatostatin receptor positive. It has a it has shown benefits in some patients, but uh, it's not strongly recommended.
Yeah, so if there is we have a study from Tata Hospital where lutetium PRRT treatment has been given to the patients and they have showed benefit. The symptomatically the patients are better off after giving the PRRT. But again, it is a therapeutic kind of a study. So therapeutic kind of a treatment what is been given to the patient who are highly metastatic and failed with the previous treatments. And there is a level 1 evidence for giving a banditinib and a cabozanthine. So you will try all those treatment. So this is kind of a hand in hand treatment you may try if you don't have the availability and the other drugs like a sorafenib or the other drugs are not available or patient is having toxicity with that. You can try this PRRT treatment. Right. Just tell me, just to summarize, suppose this patient has got a lung metastasis, the parenchymal lung metastasis, and got a liver metastasis of 2 centimeter and a lung metastasis. So, will you do a thyroid surgery for this patient? Same patient.
I'll still do a thyroid surgery for this patient too because ma'am, the clearance of thyroid and bilateral neck will improve survival in this patient.
Suppose the larynx is involved, the tumor is tracking around uh, the both almost recurrent laryngeal nerve. So, will you do a surgery and the extent of the surgery in that case?
If it is an extensive disease in the primary lesion, palliative treatment like the TK inhibitors could be more preferable than surgery.
Will you do a surgery or no surgery for the primary?
A debulking surgery could be done for the primary, but the since if it is involving the recurrent laryngeal nerves and it is involving the trachea, the prognosis will be bad.
Laryngectomy for this patient?
What is the objective of your surgery in a patient, as Anuja's pointing out, has got a large volume disease across the body? What is the objective of your surgery?
You're correct. You were saying it. Elaborate it.
Ma'am, if the surgery is just done to debulk the lesion so that the
Palliation to the patient, and you will try to remove as much as the tumor tissue in a loco-regional level without causing a much morbidity to the patient. Okay, so you don't want to do a very extensive surgery, and you don't want to cause more complication because of your primary surgery, because you know there is a tumor elsewhere in the body. So you will be less aggressive, but at the same time you will try out and take out as much disease, aerodigestive tract around, so that you can safeguard the patient for the airway point of view, and you will reduce the burden so that the patient will have a less symptoms because of the secretory component of the burden of the disease, right?
Yes, sir.
Yeah. Anything else? I don't know. Any other question anybody want to ask? I don't think anything more about all this. Do we have time?
There's a question that is asked, any role of tracheal resection during thyroidectomy?
Did you hear the question? Any role of tracheal resection during the thyroid surgery?
Ma'am, if the thyroid the medley in case of medley thyroid carcinomas, if it is involving the trachea, it is usually not done. But if it in case of differential thyroid carcinomas, it can be done.
So the just to answer this question in a little different manner, medullary thyroid cancer is a aggressive cancer than a differentiated thyroid cancer. You don't have a radioiodine backup for this patient. So you have to see whether this patient, how much is the calcitonin level and how much is the tumor burden for the patient above the clavicle, below the clavicle, and elsewhere apart from the lung, where all is the burden. So if you have a flooded disease, you don't do a much of a tracheal resection and all that. But if it is the only site, and if you have achieved a R0 resection everywhere, the patient is a favorable patient, then you will do a tracheal resection as you will do it in a differentiated thyroid cancer.
Yes.
Okay, so because you think that is the only site left to clear and this patient will have a cure, or maybe will be having a hope of a cure, then you will do it, because surgical management is the main management for the medullary thyroid cancer.
Even a laryngectomy.
So again, a laryngectomy is a very morbid procedure. But if the patient would have had a calcitonin in 1,000 and requires a laryngectomy, and there is no other distant meds, maybe I will do a laryngectomy. But I have to counsel the patient beforehand if I can do something less than a laryngectomy for the patient. So you have to choose your patient, whether he is a favorable patient or no, and you're going to achieve anything. It is always said that the sternotomy also, you won't do it because you can do it. You have to see whether you will benefit the patient by doing a sternotomy, because you have lost the disease which is beyond which naked eye, even imaging may not pick up. So it has already reached there. If you can dissect it and take it without morbidity, then yes, you should do it. So the principle remains the same for the thing. Anything about a prenatal diagnosis of a hereditary thyroid cancer?
Ma'am, in cases with MEN2 and MEN2B mutations, if we have the patients who are either the father, the uh, parents who are positive for MEN2B mutation, the prenatal diagnostics can be done to see for the mutation is carried in the fetus, and prenatal genetic diagnosis can be done to remove the ret mutated cells from the normal cells so that the mutation is not transferred to the progeny.
Yeah, so you will do a prenatal diagnosis in the first trimester or a second trimester, and you will actually look for the fetal cells and look for any kind of a directed single mutation exon study you will do, and then you can detect whether this patient will go for abortion or no, depending on whether if it is a kind of a higher kind of a highest risk kind of a tumor like 918 kind of a patient, or a 634 kind of a mutation. These are the patient where you will, but again, it has to be done with a very well kind of a genetic counselor. It cannot be done just like that. Okay, right. So it is a amniocentesis and the chorionic villi sampling. Early trimester, first trimester, you will do a chorionic villi and amniocentesis in the second trimester. And if you want to do a pre kind of a implantation kind of thing, then you will look at the embryo and see the selection. So whichever are without mutation, those are actually transplant, and in vitro studies are done so that you eliminate the germline mutation from the baby, and then the chances of the pregnancy also highest for that.
Yes.
Right. What is the treatment of a oligometastasis setting? Somebody asked this question.
Sorry, ma'am.
Oligometastasis. How you will treat the oligometastasis? Will you operate the distant mets?
Sir, if ma'am, if the metastasis is in of I mean, if it is in the distant metastasis area and if it is a localized mets, it can be operable. Like in lungs, lobectomy, partial lobectomy or pneumonectomy can be done. In thyroid, the chemoembolization can be done, and brain also a part of the lobe can be removed, or EBRT can be given to that.
So the thing is, you need to know where is the bed and how much is the burden. Oligo means it's usually in a medullary, it is like a single site or a double site, very small lesion, not much of a morbidity. If you do the surgery, then a surgery is the management. Otherwise, you will go for a kind of a intra-arterial chemoembolization. You can go ahead, or you can do a stereotactic radiotherapy to the particular distant site, or you can give a local treatment for this metastasis so that the symptomatically the patient is better because you have given a radiotherapy to this patient. Right. So you told us the we have gone through the whole different kind of familiar and the sporadic cancer. So which one are the worst cancer? What is the order with which you will have the you will place it? Suppose the patient has got a familiar cancer, patient has got a non-sporadic cancer, patient has got a MEN2B cancer and MEN2A cancer. So how you
The MEN2B will be the highest, the severest,
highest aggressive kind of a tumor, then
followed by MEN2A,
right, that is uh, 630
634 and 880, 634 mutations and other mutations.
3 maybe.
Yes, ma'am. And
And
followed by the sporadic cancers,
okay, and the last one will be the
the familial.
familiar ones, right? So if the recurrent laryngeal nerve is involved in a medullary thyroid cancer, what will be your approach?
If it is involved preoperatively, uh, uh, though you can, if it is involved, ma'am, if it is involved preoperatively, then the surgery will entail resection of the recurrent laryngeal nerve, because we don't have any radioiodine ablation post-operatively to give the patient.
So you will be aggressive and meticulous achieving the R0 resection,
Resection.
but you should achieve R0 resection everywhere, and then only you should sacrifice the nerve if it is required. And unilateral is far, means you will always try to have a unilateral kind of a sacrifice of the recurrent laryngeal nerve, because bilateral will add to the morbidity. And most of the times, whenever you require a bilateral recurrent laryngeal nerve, the disease is R plus in most of the places. So you will try to balance between the surgical extensions, surgical resection versus the tumor burden what you are leaving behind. So that's how you will assess. So if it is the only site of the disease, then you will sacrifice because you don't have a backup of a radioiodine. What is bystander effect?
In cases of, it was previously thought that the patients with medullary thyroid cancers, because of being parafollicular cells, the radioiodine ablation may kill those parafollicular cells along with the follicular cells. So, but it is not recommended to do radioiodine ablation because the studies have shown that it is not useful.
Yeah, so very true. So the thing is, you have the follicular cells juxta to the parafollicular cells. So whatever is the remnant, these follicular cells will pick up the radioiodine and it will transfer that radioiodine effect on the tumor bed and the thyroid bed, and it will have some kind of a response. That was the thought process behind giving the radioiodine in a patient. But what they have done a 60 odd patient and they saw there is no benefit versus not giving it. And you can give it if you have a tumor.
Poorly differentiated
No, if you have a mixed tumor
with
where you
PTCL.
have a papillary or differentiated component along with the medullary as a distant mets, then you will give a radioiodine. That is the only time when you will think about giving a radioiodine to these patients.
Yes, sir.
Could you tell us about the FIO, when to start doing the screening and how far you will do the screening for the patient?
Highest risk and high risk cases, the screening starts at the age of 11 years. And if uh,
Moderate?
and by 16 years, if it is on the way elevated, the urinary or metanephrine, it can be removed
So 16 years. And when, how frequently you will do the screening?
yearly.
Yearly or
Six
yearly?
monthly, initially 6 monthly for 1 year, then yearly.
So you will do it yearly. And depending on the codons, what are the positive codons, depending on that you will do it. Right. So when you will do the red proto-oncogene testing, I'm not talking about medullary thyroid cancer, otherwise.
Patients who have family history of thyroid cancers, or patients whose children are previous children are red proto-oncogene positive, or have history of medullary thyroid cancers. Before if the patient is now pregnant, there's a lady who's pregnant, will do a red proto-oncogene testing.
In any patient with a Hirschsprung disease, you will do a red proto-oncogene?
Ma'am, in MEN2A mutations, ma'am, sorry, with
Yes, you
yes,
will
ma'am,
do it.
MEN2A mutations with
If a
Hirschsprung's disease.
Hirschsprung patient comes, there is a chances that 20% they can have a medullary thyroid component. So it may be a part of your MEN2A variant. So you should do it. Then if somebody has got a cutaneous like
CLA.
amyloidosis, then again you will do it. The family members has got a thyroid cancer, then you will do it. What is the advantage of doing a red proto-oncogene for the carriers? What we used to do earlier when the red proto-oncogene was not available?
Sorry, ma'am. If the carriers, the advantage of doing a red proto-oncogene mutation.
Yeah. So earlier when we were not having a red proto-oncogene available, what we used to do and what we are doing when we are having a red proto-oncogene, and what is the advantage they have got? It's the answer in that key. That's why I'm asking you the question.
Ma'am, when there was no red proto-oncogene mutation,
We used to do a serum calcitonin
serum
to
calcitonin levels. Yes, ma'am.
yes, we used to check whether it is rising or no. We used to do imaging, sonography, and all those things. So, if the red proton is available now for the carrier, suppose there is a 20 people in the family, what you will do? You will do the red proton. Then what happens to the family of 20?
Ma'am, if it becomes, if there are no features of Hirschsprung's disease or CLA or other features of MEN2 or MEN2B, it gets categorized as familial medullary thyroid carcinoma. If they have features,
If they are red proto-oncogene negative, you don't need to do any kind of a serial investigation for this patient. So they are out of this follow business. So you don't require to do it. So the carrier out of that 20, maybe 10 patient, maybe a negative patients. Okay. So negative patient yearly doing all these tests, you don't need to do it. So you will take out them from the periodic testing if they are tested red proto-oncogene negative for that particular family mutation type or a pattern, whatever they are having. Okay, that's the big advantage for doing a follow-up of these patients.
yes, sir.
Right. Okay.
Any more questions in the chat, Prathamesh? Or comments?
What is the most common site of metastasis? The liver or the lung?
In the lung, in medullary thyroid carcinoma, the lung.
I think most of the topics have been already covered. Anuja, you have any other question?
Yes,
You're an encyclopedia.
there are many more, but the thing is, it may be too much. I think they need to go back and read the ATA guidelines, which is a very good guidelines for the medullary thyroid cancer. And there are lots of papers which are like looked at the medullary thyroid cancer. Any recent advances or the future for the medullary thyroid cancer, you can say, just to complete the whole session. Recent advances which are people are looking at for the high burden distant meds.
Systemic therapies in other molecules like the targeted
What
therapies of
about
MK.
any tumor vaccine?
No, ma'am.
So there is a dendritic cells association, and then you basically develop a vaccine against the calcitonin and CEA as an antigen. Okay, so you can have a tumor vaccine coming up in a medullary thyroid cancer. Anything else? Immunotherapy, radio label immunotherapy.
Ma'am, the octreotide is also radio-labeled
Right,
immunotherapy.
right. So octreotide, CEA label kind of a radio label immunotherapy, all this treatment can be tried uh, as a future immunotherapy thing. But it is again in the pipeline, it's in the future and must be very expensive to come into the real clinical practice. So the main thing is doing a good surgery in the first go.
Yes, sir.
Suppose the patient comes with the hemithyroidectomy done, and the earlier report was the FNAC was only Bethesda, some 4 or 5 like that. And you get a report saying that it is a medullary thyroid cancer. So what you will do?
Ma'am, if it is a medullary thyroid cancer, and if I'll check again the serum calcitonin levels and serum carcinomatoc antigens, and if it is they are raised more than 20, I'll go back and do the completion thyroidectomy. Uh, Also, because there is 100% chance of the other lobe being developing into a medullary thyroid carcinoma. Thirdly, since the follow-up of these patients is not with a radioiodine ablation scan, the tissue which is remaining will have to be removed. And based on serum calcium levels, if it is more than 150, I'll do the imaging for the lymph nodes of the neck and for distant metastasis and see if the lymph nodes or anything is remaining. I'll in the same surgery I'll remove with the completion thyroidectomy. I'll also do the compartment clearance of the lymph nodes.
What is compartmental dissection?
Ma'am, in patients who have previous surgeries done, that is either ipsilateral nodal, ipsilateral lateral neck clearance or a central compartment clearance. If these patients have a recurrence in the nodes,
So
we can
tell
just
me what is compartmental neck dissection in a medullary thyroid cancer?
I'm removing only the nodes which are positive on imaging.
So basically, this is the concept which is developed by a Drales group. Okay. So the thing is, you will treat a one compartment, like a central compartment on the right side, or central compartment on the left side, or a lateral compartment on the right side, or a lateral compartment on the opposite side, left side, and the superior mediastinum. These are the different stations, and depending on the calcitonin level, you will do a complete one component as a dissection, so that you are clearing out all the fibrofatty tissue in that compartment, so that you are not leaving behind anything, so that you don't have to go back later in that compartment. So you don't do a berry picking anyways in this cancer. You will do a complete compartment, so it is level 2, 3, 4 as a compartment, as a lateral compartment together. You will do it. You won't do it as a incomplete, just doing a level 2 or just doing a level 3, or doing a central compartment half-heartedly. So that's how you have to do it. So you have to treat it as a one single compartment, and that's how you do it. And this will reduce the calcitonin level also. So there will be a micrometastasis in the fibrofatty tissue. That's why there is a kind of a dissection people used to do is called as a tissue dissection. So under the microscope, you can remove the all the fibrofatty tissue above the clavicle, so as to achieve a near normal or a sub level of a subnormal level of a calcitonin post-op, right? Just coming back to the question I asked you about a hemithyroidectomy done and patient comes to you. So you just do this patient's workup as if this patient has come as a per primum, and you will evaluate and do everything as if you have done it as a per primum case. So you will go back to the red proton cogen distant metastatic workup, whether the calcitonin, what is it, CEA, PO, everything you will do it as same as the per primum case, and then you will categorize whether this patient warrants a completion surgery or no. And most of the time he will, because medullary we know how it present, but very rare scenario you may not require to do it, but that is in a very rare situation. That is the group of Japan, how they have selected a very low risk medullary thyroid patient, where you can only do a chemotherapy and get out of it, right?
Yes.
The concept of compartmental clearance, I think, is extremely important for the surgeons to understand, because later on, when the calcitonin levels go up, you really do not know where to look at. Sonography and imaging is some help, but if you've done some compartments really well, then you can focus your attention onto those that you have not done. So I think this point that you just mentioned, Anuja, was very important. The other thing that surgeons need to know is that clearing the superior mediastinum by the transcervical approach is possible in medullary cancer of the thyroid, but very often it's not as easy as it is for a differentiated thyroid cancer. The papillary thyroid cancer metastases come out much easier, whereas the medullary cancer thyroid lymph node metastasis may not come out so very easily and may need a sternotomy more often. Very rarely have we ever had to do a sternotomy for PAP thyroid, but for medullary thyroid, time and again you have to do it because you're not able to clear those very well. If you want to achieve a complete clearance of that compartment. I don't know what you feel, Anuja or Prathamesh.
Yeah, I totally agree with that. The medullary thyroid cancer, the tissue planes and the involvement of the surrounding structures is totally different than the differentiated thyroid cancer. And you need to be little aggressive because you don't have a backup, and it is going to be little difficult plane. So you will have a little low threshold for doing a sternotomy because the planes are not good, and there is a fear of having a vascular injury or uh, causing a problem to the recurrent laryngeal nerve lower down.
I feel that the first surgery has to be the best surgery, and that is of prime importance in medullary CA thyroid.
Yeah.
So all this discussion that we have had about doing ipsilateral and avoiding lateral compartment is okay, but as a standard practice, what we used to do and we should continue is to do a bilateral central compartment and bilateral neck dissection. That is the most important thing that will actually reduce a lot of tumor burden. And as Anuja talked about Tissel's micro dissection, though it may not have reduced or the recurrence pattern, it has certainly made a dent into the amount of tissue recurrences. So the more you have cleared all the lymph nodes, the possibility of recurrence in that area is extremely low. So we are looking at a group of patients that are very few in number. So if you're looking at 100 patients, you may have 5 or 6 medullary CA thyroids in your practice. So it is very difficult for us to adhere to these guidelines in all of these. So please do your best as far as you're concerned. Do the red proto-oncogene. Remember that this is possible to do it at that hospital at no cost to the patient. So all your patients that have medullary CA thyroid, please send them for the cancer genetics clinic. The blood will be drawn and your patient will get the report. No doubt it takes about 8 to 12 weeks, but that report is very vital going ahead in the management. So you need to do all this for your patient irrespective, because you know that you have germline mutation even in some solitary nodules. So it is very important to do all this for your patient so that the documentation is complete going ahead. And medullary thyroid is a curse, as Dr. Pradhan had always told us. It's a curse of the calcitonin. So you would have your patients coming with very high calcitonin and no symptoms, and that is most of our patients come into that category. They are asymptomatic and they must be having thousands of calcitonin. So you need to really understand which of the patients you will want to investigate, because as you heard, there are so many investigations you can do, but finally it should help the patient. You may not be able to do anything in spite of documenting that there is a metastatic disease. We have so much of tyrosine kinase inhibitors available, but remember they are given only when the patient is symptomatic. You will not, even the medical oncologist will not prescribe it as soon as your calcitonin is high. Only and only if your patient is symptomatic will these medications benefit, because understand that the complications and morbidity of these treatments are very high.
There was a question on the chat whether level 5 is included in the lateral compartment. I think it should be.
Yes.
I think barring level 1, all other nodes, cervical lymph nodes, are at risk. To me, if there's no lymphadenopathy, central compartment clearance is a must for medullary cancer of the thyroid. It is a must. And if you're doing lateral compartment clearance, it should be not just 2, 3, 4, but 2, 3, 4, and 5. One can be spared. You agree?
Right, sir. Absolutely.
So as we have it in squamous cell, like we consider as 2, 3, 4 as a selective neck dissection. in a larynx cases or in a oral cavity cases. So in medullary thyroid cancer, 2, 3, 4, 5 is considered as a selective neck dissection.
Correct.
Absolutely.
Particular about the histology, Dr. Manu, about medullary thyroid cancer, we did not touch upon that, just to complete the whole thing. And any medullary thyroid cancer types, how you have it in papillary variants like that?
The medullary thyroid cancers may have variants of oncocytic, plasmacytoid, uh, uh, or oxyphil cells. They may have clear cells. Uh, these are the variants. It maybe spindle cells which may be confused with sarcomas, or
These
plasmacytoid cells which may be
are
confused.
histological cells, what you will see when you are doing a grossing and the microscopy, doing the microscopy of the tumor. The main basic types are classical medullary thyroid cancer. Then you have amyloid rich kind of thyroid, medullary thyroid cancer. Then you will have an insular, trabecular, and something called as a epithelial kind of a variant. And the lower three will be a bad kind of a tumor tissue where you will have a adherence to the surrounding structure, like how you have the, so these are the types where you will have the planes indistinct, a diffuse kind of a involvement and all that. So these are the histopathological diagnosis. You won't have it beforehand in a preoperative setting, but you will know that this is a bad tumor. So you have to look for the amyloid, which is the characteristics of the medullary thyroid cancer. And as the amyloid decreases, there is a more of a de-differentiation of the tumor. What is C-cell hyperplasia?
C-cell hyperplasia is a continuum of change of events which leads to the medullary thyroid carcinoma, or it may or may lead to medullary thyroid carcinoma in which the parafollicular C cells, they undergo mutations and hyperplasia. If the mutations are persisting and there are changes, it may lead into a medullary thyroid carcinoma of the MEN2A, MEN2B variant.
Right.
Question,
You,
you have a, sorry,
yeah,
rising,
go on.
rising calcitonin, but no evidence of loco, regional and distant mets on imaging. What you will do for the patient?
Ma'am, if there is rising calcitonin levels but no evidence of any distant or local mets, or the patient is asymptomatic, the patient can be observed.
Right. So if the patient is not having any symptoms and there is no evidence of a structurally presence of a disease anywhere, you are not going to chase the calcitonin level. Suppose the patient has got a rising calcitonin, patient has got a disease in a central compartment. So any other uh, evaluation you will do, and patient requires a major kind of a resection in a central compartment, and the calcitonin level is very high.
Ma'am, I'll do the distant imaging for distant metastasis also, just to rule out, just to see.
Metastasis, but the patient has got a 2 centimeter nodule in the central compartment, may land up doing a kind of a major surgery. Patient has come after, and the calcitonin doubling time is like around between 6 months to 12 months.
You can carry on observing the patient and see for raising calcitonin levels, or imaging findings to see for the tumor burden and decide accordingly.
So there is a school of thought that if you have a local disease and you are going to do a morbid kind of a procedure or planning a morbid kind of a procedure, and patient has got a high calcitonin level, you were thinking there is a distant mets but which is not picked up by the routine investigation, then you will do something called as a laparoscopically looking at the liver parenchyma, and looking at and picking up if there is a liver mets or no. So open or a laparoscopic looking at the liver metastasis will pick up the distant mets which was not picked up by the any kind of a imaging beforehand. Even the venous sample also, selective venous sample also does not pick up. So the high rate of picking up. So you can make a decision about whether you want to do a morbid surgery in the neck, because now there is a presence of a liver met. So you won't be doing a morbid surgery for the patient. You will hold on, you will just do a R plus R1 resection and not to do a morbid procedure when you are picked up a liver mets in this. So you will use all the parameters available to guide you and to decide a treatment and a management plan for a patient in a recurrent situation. You won't jump and just do the surgery. You will assess how is the prognosis, how is the patient doing otherwise. Somebody is asking the role of ethanol injection. When you will do a ethanol injections?
Localized hepatic mets, you can give ethanol injections.
Ethanol injections are mainly done for the surface metastasis.
Okay.
Like so any cutaneous kind of a lesions which are accessible, which are available, there you will do a ethanol injections. I don't know on the liver.
Not in the liver, Manu. Not in the liver.
Not in the liver. Liver you may do a kind of a stereotactic radiation or
You can do RFA ablation and all. You won't do a ethanol injection.
or a surgical resection you can do it, but not a ethanol injection. Injection is done for the cutaneous mets which are accessible. You can do it at multiple sitting and multiple levels. You can do it, which is accessible doing the injection.
Right.
Still more to read, Anuja?
Lot to read, sir.
Okay.
Well, means what it looks like.
Thank you very much, Anuja. This was really good and really useful. And I'm sure when I'm seeing it on behalf of so many delegates who are listening to you. So very good. And it's so very nice to see you on the screen.
Thank you, sir.
Thank you, Anuja. Thank you very much. Thanks, Prathamesh. Thank
But
you.
we have to thank Manu. He has really done extremely well
Yes.
again today. So I
Yes.
think he's done a good job.
Yeah, he's going to get into Tata Memorial. He's a determined person.
So he really read till 6 o'clock. He read everything available under the sky. He has read about the medullary thyroid.
Yeah, he's very good. Very good. I can tell you about his work also here. He's very good. He's really dependable person. Thank you very much, Anuja.
Thank you, sir.
Thank you. Thanks.
Thank you, sir. Bye.
Thank you.
Thanks, Anuja.
Thank you, Professor. Thank you. Thanks a lot.